Good morning, my YouTube channel. Thank you very much for following me, for subscribing, liking. I really appreciate it. I hope I'm bringing you some interesting cases. So what we have here is how the age. So this is a young lady, a small 80-year-old girl with history of JRA uveitis, juvenile rheumatoid JRA, idiopathic arthritis, and uveitis. So she's been diagnosed about 3 years ago, and she was not really controlled. When she came to me, she was 3+ cells. You see the band keratopathy already there. She had a vision of count finger, and we started treatment with the assistance of the rheumatology staff, and thank God we were able to control the inflammation. So and then in December 2020 she was stable, and I recommended cataract surgery. However, the patient were not able to do it at that time, and today is we're in the middle of April. So we're gonna go ahead and do this cataract surgery. Because of the uveitis, severe uveitis, I'm not implanting an IOL at this time. So we go ahead and start by doing paracentesis incision. So you see there's fibrosis, anterior capsule of fibrosis. So this is not gonna work. Putting some okay, viscoelastic, and I'm gonna use the vitrector also to help me. Okay, so Sinsky, I want please Sinsky. Okay. No, that's fine. 1 second. Just give me yes. Thank you. So the plan is to do cataract surgery, remove the. So we're gonna go ahead and start by removing, breaking all the synechiae. Okay. See if I can go ahead and you know, the difficulty in these cases is doing the capsulotomy. So you see this membrane, use uveitic membrane, pupillary membrane, which causing the. So still I'm not touching the capsule. This is not the capsule. This is part of the membrane. You see? There. See, I'm gonna use my Utrata keratome. I'm gonna use my Utrata to remove this. It's 360. Okay, here we go. Utrata. See, it's bleeding. So here, give me the other Utrata, the big Utrata. This. Okay, it's huh? What? Serrated. Yeah, we'll do serrated. Yeah. This is not catching it. So I'm gonna use I'm a vitreoretinal surgeon, so I have my micro instruments, and they're extremely helpful in you know, and anterior segment surgery as well. So if you do complex anterior segment surgeries, you need okay. So now Y hooks. So I use the Lester and Y hook to kind of, because I may not need to use hooks in this case. I'll see if I can stretch, because I'm 90% of the time I'm successful just stretching the iris. Viscoelastic, please. Stretching the iris without needing to use iris hooks. So okay, see the plaque. It's a capsule plaque. That's what I call it. Okay. I have the Coughlin hook and the Y hook. Okay, so we go here, one here, and okay. See the iris attachment there. Ooh, peripheral synechiae. Go ahead slowly. The family had lots of issues with scheduling the surgery, and the surgery was really late. But and the thing I'm happy about is that the patient is stable, and as far as the uveitis goes, she was controlled nicely. And this is a huge plaque. I thought it was just a tiny plaque, like anterior, just around 2 millimeter, 3 millimeter plaque. But obviously this is the entire anterior lens capsule. By the way, when I talk, apparently my surgical assistants tell me they don't like it a lot when I record videos, because I'm slower than usually, because I take more time to talk this through with you guys. So I hope you guys appreciate this by subscribing, liking. Okay, so in this case it looks like this is really tough. Yeah, I mean, it's fine. Here we go ahead. My assistant Sarusht offered the cyclodialysis spatula, which is a much better tool in these cases, because he's an experienced assistant, and you really need to have a good assistant when you're doing these kind of cases. Let's go. Give me I'm gonna try to just trip and blue.
Give me 3
Okay. Try to put your. Okay, it's pretty easy. I mean, I can take care of this pretty easily with the vitractor. So I'll go ahead and do that, but I just want to see if I can paint the interior capsule. Maybe it will help me, even if I get a small painting of the interior capsule. I think it will help. It doesn't need air. No, it's okay. Viscoelastic. Go ahead. Yeah, I got a nice. So I'm gonna try to use cystotome. I'm gonna try to do it the traditional way. Yes, cystotome. I'll try to do it. Music. There. Viscoelastic, please. Lights off, please. Okay. There's this. Okay. Capsule. See, it stopped here at the fibrosis. It stopped. So I have to kind of shear it here. Continue the capsulotomy. Viscoelastic. But either way, this is a very small capsulotomy. So it's shearing this way. Okay. This is a child, don't forget, it's an 80-year-old girl. So I got a continuous curvilinear capsulotomy, but you know, let's see. But I think that's not gonna be enough. All the okay. See if I can get the IA and see what I can get here. And then I can switch immediately to vitrector. So I have both standby now. So I have the phaco machine, I have the vitrector, please. I don't think this is going to do anything to the plaque, but okay, so this is a soft lens here, and this is not allowing me to do anything. This cannot be removed. So you see, so there's no point of continuing, so you just need to go ahead with the vitrector. And okay, so we're not 5,000 cut rate vacuum, full vacuum, and then you see you put the mouth of the vitrector inside this membrane and you just start cutting. Sometimes because the membrane is so tough, remember this membrane goes all the way out. Cut rate 2,000. When it doesn't cut, you have to reduce your cut rate. Allows the membrane to get in. So it's eating it slowly. $1,000.
1,000.
Okay. I go this, so I keep the mouth like this. This is, you know, this is a 25 gauge, so it's not going to be as effective as a 20 gauge or 23 gauge. But this is what I use. We got some iris here. It's very thick membrane, very. I know I'm gonna get some capsule here, but see, I don't want to remove the lens matter before I remove this. The lens is acting as a cushion for me, so I can take care of this membrane. So yeah, it takes a while. 500 cut rate.
100.
500. 500. Down. 500. Not 5,000. Yes. Thank you. So, oh, it's barely cutting. Okay, go up to 2000. It's not cutting anymore.
2000.
That's what I'm gonna do. This is very tough membrane. So viscoelastic. So we're gonna do some complex stuff now. Okay, if things doesn't work out, you can't just continue doing the same thing. Okay, this is, you have to change your strategy. You can't just continue doing the same thing. I want an ILM forceps and I want an MVR. So I'm gonna hold the membrane and I'm gonna cut it with the MVR. Sharp MVR. Yes. ILM. Okay. MVR. Yes. Thank you. I'm holding it here. Going through the here, not look, and then make sure you don't cut the you will have to watch the interior part of this. So tough. Okay, Vanus. Lights out, please. This is like very tough. Almost has a sound when I cut. Oh no. Okay, we can. Okay. Push down here, this will come. They're still stuck here. Come here, baby. Yes, it's out. Goodbye. I know I'm eating a little bit of the iris tissue. Actually, that helps me examine the patient later. I know. So, okay, now, since we're done, and I have the vitrector, I'm gonna go ahead and do some BSS. I'm gonna go ahead and do some iridectomies. One. I know they close, so this is important for glaucoma in these patients. So here. This makes things much different. Please. Very thick iris. because you can't do this with the kids in the clinic, so it's really important to do that now when you can. So I this, you know, so please dry the, yes. Okay, now since we removed the membrane, we're gonna go ahead and go ahead and then remove the, look at this stuff, man. What the hell is this stuff? Crystallized stuff, crazy, man. Look, now we remove this stuff. The cataract. Music. Oh, they put. Now Kaka Govend is working with us to BSS. Okay, so remember we couldn't hydrodissect it very nicely, but you just have to be patient and let it come to you. Okay. In these cases, I am going to do an posterior capsule. This is what I plan. I plan to do posterior capsulotomy. And in the past, we used to do the capsulotomy also with a Utrata, and but now with the 25 gauge, you can do a very nice continuous curvilinear posterior capsulotomy. You know, there's a lot of studies on doing that for kids for congenital cataract. Okay. Okay, so we're good here. Look at this piece. Look at this, man. This is crazy. Like very, very thick. This is inside the capsule, inside the lens capsule. And try to go ahead and try to polish as much as I can. Please, maybe this clogged the aspiration, so we're gonna go ahead and flush the aspiration. Now I have a very nice 2 iridectomies, look like a smiley face. No, like a very ooh face. One of the best things ever is to do iridectomies. I mean, and your surgeries for patients who have glaucoma, who you're doing phaco-vitrectomy. It really makes a huge difference. So I'm gonna go ahead and see. I want the sulcus to be nice, so when I implant the IOL in a few months time, I will not have issues. Looks like here, nice. Yeah. Yes. Yeah, see, there is some. Yeah. Huh? I wish I could take more of this, but you know, that's all I could have done. So trying to get the right, okay. Okay, so now it's time for the posterior capsulotomy.
2,000.
Yes, no, 10,000. Because I want it quick and nice and to do exactly what I want it to do.
10,000.
Yes.
10,000.
Okay. Okay, we're good to go now. Vitrector in my right hand, left irrigation. Here, we penetrated the posterior capsule. I mean, I don't know, maybe. So it's round now, very nice. And it has to be large, not small, because otherwise okay, with anterior vitrectomy. Remember, sometimes the viscoelastic okay. No. Okay, looks really nice. I think it's about the size of the iris.
Change the body.
Okay. It's just a little bit anterior vitrectomy, just symmetric, nothing is going on. And then you rotate 360 with your vitrector, so you make sure you get everything you need to get. You rotate.
I have to change the body.
Okay, we're almost done here. Okay, this color, this BSS, BSS, BSS.
You're on the line, right?
Okay. Make sure we have a sealed. Okay. So this one is leaking, so we need to put sutures. Very much support of putting sutures in kids all the time, because you never know, even if the patient is, you know, is a good patient, you never know how they may touch their eye or This should be removed after 4 to 6 weeks. 5-minute procedure under sedation. BSS, can you check if the recording is working, Govan, please?
Check both of them.
Both. Okay, so we're pretty much done here. Thank you. Okay, so please don't forget to share this with your colleagues. If you're in residency program, fellowship program, whatever, please do share it with your colleagues, your fellow residents, fellow fellows. I think it's pretty helpful. I mean, this is live narration. This is not like, oh, look at this beautiful thing, I'm just gonna show you how wonderful I did. I mean, no, this is real. You're seeing exactly what I'm seeing, and I'm reacting to the case with you guys watching. I think there's a very nice sulcus, and we can do put a sulcus later on, sulcus IOL. So the key is, honestly, is to have the tools for this case. It's not that you can't do it. I mean, pretty much, probably everybody can do this maybe, but you know, the problem is they may get into the OR and not having the tools, the special tools to deal with such cases. I mean, I knew exactly what I was dealing with. I had these many cases like these in the past, and you just need to know what to do. Using the MVR is great because, I mean, if it wasn't for the MVR, you'd be eating this all along. I mean, except if you are using a 20 gauge or 23 gauge, yes, you may have a better chance than I did with this membrane. But, you know, what if you didn't? What if you're a 25 gauger? 25 gauger, I like that. Oh, and somebody would say, who says that's why you're not? You are using 25 gauge, that's why you couldn't do it. Well, I use 25 gauge for all my cases. I never have problem for that. It did help me start the case, and then the MVR completed the membrane. So because I hydrated, this may not bury in nicely. Yes, come on baby, come on. BSS. .1. So okay, BSS. So I'm gonna, sometimes if the eye is not inflated, it doesn't. So I can see. Tie, please. Okay, no. Yes, thank you. So now is a little bit. I don't want this girl, poor girl, to feel foreign body sensation for a whole month. See, it's nicely buried. Just, you know, try your best for your patients all the time. Always. I mean, this is what makes us go home and feel happy about what we're doing, because you know you did your best for them. So the pressure is looking good. I feel the pressure is nice. Okay, Vigamox. intracameral Vigamox. Okay, I'm gonna go ahead and check for any leakage again. Always check, double check, triple K, check. Looks nice. Watertight incisions. Beautiful. Wash, please. So again, thank you very much for following this channel. I truly appreciate what you're doing and helping me get this channel up for everybody to enjoy and use. Okay. No. Fine. Thank you. So again, thank you very much. He was asking me if we need to use any injections or anything for that. No, the patient is already started on oral steroids perioperatively, and you know, and she's already a steroid responder. So again, thank you very much. Have a good day. Please share, subscribe, and like. Please, please, please. Thank you.